gospel music videos, gospel movies, inspiring teachings, educational programs, and lots of other exciting programs on Livecom TV. Livecom TV.
Good evening, viewers, and welcome to tonight's program with Dr. Ajayi. I'm a psychiatrist and also a substance misuse specialist. We thank the Lord for another opportunity to share with each other about things that can help us improve our lifestyle, mental health, and also this can impact on our spiritual health and our physical health. In the previous episodes, we've talked about alcohol in you, which we talked about last week. But I would like to thank people that have given me feedbacks and comments and phoned me to give me their views about the last episode that we have. And based on this, we're going to be looking at depression on its own tonight, unanswered questions about depression. Because from the comments and the reviews that I've had about last week's program, people wanted clarity on certain things with depression, and we couldn't go in depth into this last week because we're just looking at various aspects of depression, especially when people lose their coping mechanisms in life. And this can be spiritual coping mechanisms, it could be emotional coping mechanisms, it could actually be physical coping mechanisms. The loss of these mechanisms can make things very difficult to manage for people generally. So as we trust the Lord tonight, as we trust the Holy Spirit to host us himself, and as I subject my intelligence and my knowledge to the Holy Spirit to help us and guide us tonight, I believe that the Lord will help us to kind of break down into bite-sized issues about depression and unanswered questions that a lot of people might have. Some of the things we're going to talk about tonight are based on some of the reviews that I've gotten from people, like I said. And I'm hoping that this will cover mostly what people want to know about depression. We will also be looking at, in subsequent episodes, about comorbid substance misuse and mental health. And this means that you have mental health issues and substance misuse occurring at the same time. And that's one of some of the things that we will also look at because I've also had questions regarding this. So, but tonight we're going to look at depression. What are the symptoms of depression and how is it diagnosed? And what are the different types of depression that we have? What causes depression itself? And how is depression treated, or what are the various ways in which depression can be treated or managed? And what are the treatments that can be offered for somebody who is depressed, for instance? And also, apart from what can be offered by professionals, what are the things that you can do, or family can do, or relatives can encourage you to do that might improve your symptoms? And what are some of the risks or complications that can arise in somebody who's depressed, for example? And where can family, friends, and loved ones find questions about depression? Sometimes people confuse sadness and depression. We can all be unhappy and sad about certain things or about situation or circumstance, but this should not extend and it should not proceed for months on end or weeks on end. And this is where the difference between depression and just being sad or unhappy can be differentiated, because usually when somebody is low in mood, or like people will say, I'm feeling depressed every day for more than 2 weeks, there has to be something else going on apart from sadness or just being unhappy. And this might necessitate the person actually seeking help. First of all, usually it's from the GP. And like I said, when the program first started, as a clinician and as a Christian, I can see things from both perspectives. And I personally believe that the Lord that we serve is an awesome God. And He was giving us everything to freely enjoy, including specialists and doctors and professionals. And so we must not shy away from seeking help from specialists or our GP, especially if we're not feeling well, if we're feeling unusually sad and depressed. And we'll talk about some of the symptoms that will imply that somebody might be depressed. And the different things that can lead to depression also, such as upbringing, stressful events, lifestyle, can also present with symptoms of depression. And this we'll also talk about briefly. And depression can actually come on and off. And when people are even being treated, you might have that, especially in severe depression, in which extreme cases of things like electrical therapy that we call ECT has been used. This might fade out, and it might need some constant repetitive treatment with some of the newer treatment that we call transcranial magnetic stimulation, which we'll talk about. It's big English, but I'll break that down to us later. So what's depression? It's a mental illness that is recognized all over the world. It's not peculiar to any tribe or peculiar to any color. It's not peculiar to any person, sex, or individual. It's a long-lasting low mood that prevents somebody from functioning and able to live from day to day. And that's the significant bit of it. You cannot function. And that's when you realize that this is just not sadness or unhappiness, but this is becoming something else. It's very, very common. Mental illness generally affects 1 in 4 people. Within the UK, we know. But 1 in 10 of us will have depression. And so it's quite common. And it's something that is treatable, and it's something that is manageable. So there's really no reason or excuse for somebody to be depressed and suffer in that depression when there is help out there. So, like I always say, we as Christians, we need to pray. I'm not saying that we shouldn't pray. You pray, but you seek help and support. I can tell you from being a clinician of many years that people go to hospital and they get misdiagnosed. People go to hospital and they don't get the support they want. And so prayer is a source of help for us. We go to hospital, we see the right people, we get diagnosed, we get treated properly. It's an answer to prayer. And I can give you testimonies and testimonies of people who have been able to testify to the glory of God and their experiences when they were feeling unwell to be the result of God's intervention. So you pray, but also you seek help. And like some people confuse depression with something very simple. You just can't snap out of depression. And it's not a sign of weakness. And it's something that is common. And it's something that we all need to be aware of. And it doesn't last forever as one single episode. And that's why sometimes people think that because they've overcome depression without seeking any form of treatment, then it's gone forever. No. It can affect any age, including children. And it's one of the most common mental illnesses around. The number of people who have depression actually might be higher than we know or we can count, because a lot of people with depression do not seek support or go to their GP. So statistics might be quite low in that regard, or people might seek alternative sources of support in which we cannot capture those data, but we know that it's extremely, extremely common. So, what are the possible causes of depression? There's not a single cause of depression, it's multifactorial. And a lot of things can cause depression. I think the most significant is the genetic factor. Some people have genes that might play a role that might make them more susceptible to having depression. In recent study, which is still ongoing, actually scientists are now identifying close to about 44 genes that might be responsible for depression, but this is still a work in progress. But we also know that our background, our current situation, lifestyle, work schedule, people at work, relationship, all those things can also play a part in depression. And also, when you look at women who've had babies postpartum, they can have depression. And these are also different types of things that can present as depression. Stressful events, such as problems at home, work, in children, school issues, bullying, relationship ending, financial difficulties, threats of being made redundant, and all those things can also play a part. Hormones and chemicals, especially as it applies to our mothers and our women, might play a role, as some of these chemicals actually help to potentiate the substance that is implicated in depression called serotonin. And so when you have lack of it, like you have in menopausal women, it might affect the way they feel in themselves. And so you also have some people who, at the time of wanting to start experiencing, or the early onsets of menopause, they can have issues surrounding mood. They can be irritable. They can have other things that might relate to their mood going up and down. And also some lack of substances in the system, especially thyroid, for example. And we also know now that low levels of vitamin B12 is being implicated in the development of depression. What about lifestyle factors? We know that for some of us, being overweight, not exercising, being just sedentary in our way of life can also contribute to it. Drug and alcohol, especially, which is my field, is also something that contributes to depression. Some prescribed medication can, in their side effect, but they might be rare, but it might occur in certain people. And we know that people who drink more than 14 units of alcohol a week can be predisposed to mood changes, whether anxiety or depression. And I'm talking about the whole week. It doesn't matter whether you drink it in one day or you drink it across the week. If you're drinking or consuming more than 14 units of alcohol, you are more likely to suffer with anxiety and depression. And so we want to talk a little bit about the symptoms and the diagnosis of depression. What are the things that would suggest to you that this is just more than sadness? This is more than unhappiness. This is more than what we refer to in some women who have just had babies, postpartum blues. For example, in women who've just had babies, postpartum blues, you were expected by 10 days, maximum 2 weeks, to have kind of weighed and waned off, really, basically just fizzling out gradually, because the stress surrounding childbirth, looking after a baby, sleepless nights, and things like that can cause what we call postpartum blues. But when you begin to have this beyond 2 weeks, stretching for weeks on end, with some of the symptoms we're going to talk about in a few minutes, then you must be suspecting postpartum depression. And people who had previously had depression are more likely to suffer from this. So it's something that we look out for as doctors. So it's important for us to understand this, that somebody must not have all the symptoms I'm going to talk about tonight. But if you have at least 5 of these symptoms for over 2 weeks, then certainly there is likely to be an element of depression, whether it's mild, whether it's moderate, whether it's severe, depending on the impact on lifestyle and the functioning and how disabling it is. So doctors will make a diagnosis and say this is mild depression. We will intervene this way. Or moderate depression will intervene this. Or severe depression, because it's starting to put the person's life at risk. They'll become either suicidal or making plans or intending to harm themselves. So those are classes of depression. But most commonly, what somebody will complain of is that they're just feeling low most of the day or nearly every day. They feel sad, irritable, sometimes angry. They have less energy to do things. They don't feel motivated to do things that they normally like doing. They're not enjoying some of those things they do daily that they almost most likely enjoy doing. They find it difficult to think. Sometimes they lose concentration and they struggle to make decisions. Changing in sleep pattern is also something that is very, very common in depression. And tiredness, losing the appetite, not wanting to eat, or feeling less good about yourself, lack of confidence, low self esteem, feeling of guilt, or worthlessness that is not shifting. And this is quite important because worthlessness, helplessness, and hopelessness, it's a very, very important symptom of depression, because this can actually push people to attempt suicide or make threats to harm themselves. And severe depression can present with thoughts of death or attempts at wanting to harm self. And when people have low mood, also, they might feel less pleasure from things that they enjoy. And some of these things could also be in married couples, for example, loss of interest in sex. And so it's important for couples to note that it's not only about complaining about headaches, but depression can also cause loss of sex drive or interest or desire to be intimate. And the people can just be generally sluggish, slow, or slow down. Somebody who is very active, who's always on the go, begin to struggle. And this might suggest that this is something more than just the usual. So when this happens, the first point of call, obviously, apart from what we do as Christians to take everything to God in prayer, is to seek support and help. And the first point of call is usually the GP. And I can't stress this enough. The GP, in whichever country, there is a primary caregiver who is your first point of call for anything medical. Please book appointments. I know that sometimes people will say it's difficult to get an appointment, but when people are depressed, it's important for them to be evaluated properly by a medical professional. Men and women. People say women get more depressed than men. That is true. And this is not because women are weak, but some other cyclical hormonal changes and psychosocial factors are unique to women that make them more liable to suffering from depression. For example, we know that statistics tells us that 20% of women will experience at least one episode of depression in a lifetime. So it's important for us to know that. And especially for us fathers, especially for us husbands, especially for us men, around the time of menopause, premenopausal, there might be changes in mood, like I said earlier on, and it's important for us to note this. If it's manageable, then that's fine. But if it's becoming to impact on the life of the person, it's important for them to seek support. And hormonal replacements and other things are there for GPs to use to try and help people manage such difficulties with their mood. Because we know that hormone affects the brain chemistry in a particular way. A lot of hormones that get depleted during menopause, like progesterone and estrogen, they boost serotonin, which is quite good and important in maintaining mood. And this can impact on emotions and mood. And so when we look at menopause itself, what you have is that you have a persistent low level of progesterone and estrogen. And one of the things that you first of all see in people who are premenopausal is that they complain of feeling very, very hot. And why is that? Progesterone, which is one of the hormones that becomes quite low in menopause, actually acts on part of the brain that regulates temperature. So temperature changes and difficulties regulating body temperature, it's a significant thing that you find in premenopausal women. And also because of the fact that these two hormones are quite low, they do not potentiate or boost the serotonin like they usually would do. And so they might cause people to experience features of anxiety, of depression, of irritability, and mood swings. So, and when you look at menopause in general, you don't only have hormonal changes, but you also find out that the ovaries stop producing eggs. And during this transitional period between being premenopausal and menopausal, mood changes and possible depression can be a significant feature because the rise and fall of estrogen and progesterone, like I said, can affect the brain chemistry and cause significant mood changes. So to summarize that, estrogen increases serotonin and boosts mood, and so does progesterone, which also acts on the temperature regulating area of the brain. And some of the things people were asking me about is that, so you talk about depression. Is there only one depression or are there different types of depression? Yes, we have different types of depression. And we, as clinicians, when we see somebody and we want to evaluate them, we actually need to know what type of depression the person is suffering from. And when you find out what type of depression the person is suffering from, you also want to know how bad that depression is, because that will determine your intervention, whether there are things that you can try or things that you might have to go straight to try and manage that depression or low mood, because it's becoming to have significant impact, especially if it's becoming life-threatening. And every one of us want to wake up in the morning and feeling energetic. Well, even though some of us might feel tired from the week's work, but we still feel that we need to do certain things, and it might be an effort, but we get going. But when this becomes impossible, it could be that depression is setting or has already set in. So, what are the different types of depression? I don't want us to confuse, because I hear people talk a lot that they said I have clinical depression. Really, clinical depression is not a formal diagnosis. People sometimes say clinical depression because it's been diagnosed by a doctor, but it's actually not a formal diagnosis of a type of depression. So but we don't really find out people when they go and see a nurse, for example, who says they are depressed. They still call it clinical depression in certain cases. But when doctors do the diagnosis or make the diagnosis, a lot of people will say they've diagnosed me with clinical depression. But the phrase, depressive episodes, generally, it's a formal name that is given to depression when doctors find a cluster of symptoms that suggest that somebody is suffering from depression. And when this formal diagnosis or formal evaluation is completed, which might actually also include doing things like blood tests to find out if certain parameters that I mentioned, like the thyroid, the vitamin D, vitamin 12, B12 are not low, they will now come to a conclusion that this is mild, this is moderate or severe. So that's the severity. But we talk about depression in different aspects of life, and it can be related to different aspects of life, and I'll explain what I mean by that in a few minutes. But also somebody can have depression and it can reoccur, and this person, because they've had repeated episodes of low mood, or diagnosed depression, they might now be labeled, or let me take that back, not labeled, but they might now be diagnosed with recurrent depressive disorder. And every type of depression, whatever the cause, whatever the type, can be mild, can be moderate, and can be severe. So we need to be very, very aware of that. And sometimes we clinicians will say that, oh, somebody's got a reactive depression. And this is usually when you have an acute, stressful situation in somebody's life that makes them very low. And like I said last week, they lose their coping mechanism temporarily, but not permanently. And you can have things like divorce, for example, job loss, redundancy, money worries. But if that low mood begins to persist beyond 2 weeks, and the low mood is almost on every single day, that might be actually more than a reactive depression, and might be depression itself. And we now need to ascertain as a clinician to say, is this actually mild? Is this actually moderate? Or is this actually severe? And this we can also sometimes separate from what, not to confuse us, what we call adjustment disorder. And this might happen when there is a major change in somebody's life. When somebody makes a major change of lifestyle, for example, they must struggle to adjust to that change. And we can actually find out sometimes in youths when they're growing up and they're going from children to adolescents, from adolescents to young adults, from young adults to older people. And I'll mention to us that actually old age also, you can have depression in old age, which we'll talk about towards the end if we do have the time. And adjustment disorder can also mean that somebody might either be retiring, for example, and they don't know how they're going to manage retirement, or they might be moving from one area to another. People get posted to where they don't want to go to. They get posted to where they want to go to, but the environment is different because you don't know the people there. You already formed a social circle where you've left, and you have this group of friends that help you contain issues, difficulties, stressful situations, and manage things generally. And then you go to somewhere where there is, in quote, you are lonely and there's nobody there to support you socially. And so even though we all know that whatever happens, we have the Holy Spirit and the God as support. And in severe people, or in severe depressive episodes, you can have certain additional symptoms that might suggest that this is just more than depression. And we refer to this as psychotic symptoms. And if somebody goes through depression that is severe, especially from moderate to severe, they might have additional symptoms, which might suggest that this might also be a depressive episode with psychotic symptoms. And when we talk about severe depressive episode, we talk about severe depressive episode in the light of with or without psychotic symptoms. And these psychotic symptoms can be hallucinations, in which people hear voices of people that are not there, and they're responding to a stimuli that is not there. Usually, those of us who are not having issues like this will respond to stimuli that we hear. Somebody calls you, you say yes. You see something, you look. But if you're beginning to experience those things without those stimuli being there, then that could be suggestive of something beyond normal. Or delusions, believing in things that are not real, that are not that existing, and you hold them with such convictions that they are existing, despite the fact that everything around you are contrary to the fact that this is not the case. So in hallucinations, for example, it could affect any of the senses. But the common ones that we see are people hearing voices, and that's the commonest one that we tend to see. And or people might believe things that are not real, like I said earlier on, and we can term this as depression with psychosis, especially only in severe cases. Dysthymia is another form of depression, but this is a low level, persistent, low mood that is there for years on end, but they are not severe enough, or the episodes are not long enough for a doctor to diagnose a recurrent depression. And so they are there. But what is important is that people, when they have a very, very stressful event, can actually have an acute depressive episode on top of a dysthymic mood. And so we need to know that some people who will say, they're generally sad or they're generally unhappy might actually have a dysthymic mood. And this is a one of the persistent mood disorders because it's there for several years, and the person functions to some extent, but the mood is always low. And then if they have a major setback or a major stressful event, then it might actually present with acute depressive symptoms. In the same vein, cyclothymia is another persistent mood disorder, but this is the high as opposed to the low, in which somebody feels persistently elated but mildly, and it does not fit or it does not occur long enough for a diagnosis of bipolar, for example, to be made. But if this diagnosis is missed and it goes on for a long time, it can actually become a diagnosed bipolar disorder. And the next one I will talk to before break is postnatal depression, which I alluded to earlier on. Postnatal depression is not postnatal blues, or what people call the baby blues. It's not. Baby blues, you will expect it to disappear maximum 2 weeks. Like I said, it's usually within 10 days of somebody giving birth to a baby. And that can be explained by the first experience, managing the baby, and lack of social supports and things like that. But you will expect that will phase out after about 10 days. If it's persistent and goes on beyond that, then it might actually be postnatal depression. And somebody who's had depression before and had a baby is more likely to suffer with postnatal depression than somebody who's never had a depression prior to having the baby. And it's a common illness that we find in women and can occur in about 1 in 10 women within 1 year of having a baby. So that is actually a long period of time for somebody to suffer a depressive episode. And usually it starts with very, very mild, unassuming symptoms, and which gradually gets more disturbing or begins to impact on the life of the mother, not caring for the baby, not caring about the welfare of the baby, feeling low in mood, not breastfeeding, all sort of other things begin to show face that would suggest that this is just beyond postnatal blues, or what we call baby blues, and this is actually postnatal depression. And patients may get symptoms in postnatal depression similar to those that you find in other types of depression. So agitation, sometimes anxiety, sometimes irritability, and all other features that we have in other depression can also take place. Seasonal affective disorder. This type of depression affects people at the same time of the year, usually in winter. And the symptoms are similar to depression, but some people find that during this time, they sleep more than they sleep more rather than less. And so it can be what we call hypersomnia, in which people sleep a lot. And we also find features in which people can crave carbohydrates like chocolate, cakes, and bread. But depression is depression. So you can also find all other features of depression, like lack of interest and all those other things in the same period of time. That would suggest that this is a seasonal affective disorder, but it's a depression that occurs at a particular time of the year. Hence the name seasonal affective disorder. Manic depression. Manic depression is an old name for bipolar disorder. We now refer to it as bipolar disorder, in which you have two different poles. Somebody can be low and then can be high. And it's interesting because in most cases, bipolar disorder present with depression first, and people can have depressive phases for years on end before they have their first manic episode. Or sometimes the hypomanic episode might be missed, or might not be apparent. And so the patient might be treated for depression. And from what we know is, if somebody is being treated for depression and they actually have bipolar, that is the likelihood at a particular point in time, over the time of treatment, that the antidepressant can actually overtreat the depression. Let me put it that way so people will understand. Can overmanage the depression in which they have a manic episode, which is the antidepressant can actually precipitate a manic episode. And which is why once we are aware of that, we tend to have other things that we can use to manage the situation, like what we call mood stabilizers. Like you want to stable the mood and make sure that the mood does not cross the boundary from being normal to being manic, and does not cross the from being normal to being depressed. So finding a balance in which the person can function. But with experience, you will see that over the years, a lot of people have said to me during my practice that they actually enjoy being a little bit high because they can function better. But how do you get the balance with the medication in which you get somebody slightly elated so that they can function better and without having a manic episode? That's always a challenge. And that's one of the discussions that is always of interest when you are managing somebody with bipolar. And you need to argue the reason and explain the reason and see from their own view and try and reach a compromise of how best to manage the situation so that there are no highs and there are no lows, and somebody can have a balance in which they can function and achieve the purpose of God for their lives. So bipolar disorder, like I was saying, is when you have moods that swings from an extreme, from high to an extreme that is low. And the manic symptoms itself include things like increased energy, excitement, impulsive behavior, and agitation. Whereas the depressive component of it can be what we've talked about earlier on, including lack of energy, feeling of worthlessness, low self-esteem, suicidal ideas, and all the other symptoms that we've talked about. You know, I've mentioned interestingly about severe depression and psychosis. We can also have bipolar disorder with psychotic symptoms and bipolar disorder without it. So we can also have those symptoms that we talked about, hallucinations and delusions associated with bipolar disorder. The psychotic symptoms are not different from any psychotic symptom that you can find in normal people without any mood disorder. But what we know is that when they occur, it's sometimes a challenge to try and manage and balance the treatment in such a way that you can get the person to function and achieve the purpose of God for their life. we don't really know what causes bipolar, but we know that it's a combination of genetic and environmental causes. And like we do with depression, when we talk about the treatments and process of evaluation, we have various things that we can use to manage both depression and all the other forms of depression that we've talked about tonight. Um, Talking therapy is a part of it. Medication is part of it. Some self-help techniques and other things, activities, lifestyle changes. All those things we'll touch on briefly later on. But can we have depression that doesn't occur in somebody when they were younger, as a teenager, as an adolescent, as a young adult, and bang, they do have a depressive episode when they're older, in their later ages? Yes, this can happen. It can occur for the first time in later life. And this can be due to various factors. We know that as people get old, their brain changes, or in the brain and in the body, in the metabolism, and in all sort of other things that is happening with old age. And all this may play a role. One significant thing that we find is when we have restricted blood flow to the brain, especially because the blood vessels become less flexible with old age, and they can cause what you call vascular changes, ischemia, which can lead to depression. But in cases like this, actually, there is always a pointer to this kind of depression, because you have other vascular complications such as cardiovascular problems, heart problems, or they might have even suffered a stroke, or what we call TIAs, transient ischemic attacks, in which you have minor bleeds in the brain rather than a major one that is catastrophic, that makes everything quite obvious that the person has had a stroke. And so when somebody comes to the realization, in psychiatry, that is what we call insight. And I think insight cuts across every facet of life, really, because unless you realize there is a problem, you don't seek solution. And in the same way, just like in workplace, in relationship, in life, in businesses, if you don't realize that there is a problem, you find it difficult to look or seek for help. And so one of the things that is important when somebody has any form of psychiatric illness or mental disorder is for them to understand that there is a problem. And sometimes this might actually be difficult for the person to understand. And it might be people around them that would bring to their attention that certain things are not normal, or things are not the way they used to be, or the way they seem to be to the person who is involved or who is having the depressive episode. Because when you begin to talk to people about treatments and about what can help them manage their depression or low mood properly, what you find is that in people who don't believe that there is a problem, you kind of struggle with compliance. When we talk about compliance, is them adhering to what you have offered as solution to their problem. And it's not always the case of chemicals. Like some people will say to me that they don't like chemicals. I don't like putting chemicals in my body. That is true. Nobody likes doing that, but sometimes it's not something that can be avoided. And with depression, the various types of medication we have, you'll find out that sometimes people might have to go through two or three different courses of treatment to get the right medication that suits their symptoms. And this takes me to what we refer to as clinician as treatment resistant depression. And this can be in cases in which moderate to severe depression, for example, has been treated by various means and it's not responding to the conventional or what's the word looking for now, the treatment that we will normally offer for that type of illness. It's not responding to it, or somebody has gone through two courses of antidepressants that has been optimized to the right dose and they are still not responding to treatment. In people like that, we will be saying that they are resistant to treatment. But that doesn't mean that life ends there. There is still other ways in which we can try and manage that. That means like stepping up to what I referred to earlier on as electroconvulsive therapy, which a lot of people shy away from. And I can understand that because what we do in there is that we induce seizures in the brain with the hope of controlling the low mood. People who are not clinicians find it very hard to understand that why would you be making me have seizures or convulsions to manage my depression? But we know that this is extremely useful. But we also have people that is the only thing they respond to because they're resistant to all other form of intervention. And people need to have that when they either relapse. Because the problem with electroconvulsive therapy is that, don't forget, it's not like antidepressants or tablets that you take every day. So over time, it will fade and fade out, in which there might be a need for the person to repeat the process again. But with advances in research, we now have something that we can use now for such client group, in which we can give them repeated transcranial magnetic stimulation, which can be given repeatedly to kind of sustain a period of normality, or at least try and manage the mood so that they can function normally and enjoy the benefit of what the Lord has proposed for their life, and so that they can fulfill destiny. So when we come back from the break, I'm going to be talking to us about what we do when we want to evaluate people with depression, and how we come to our conclusion, and the different types of intervention or treatment that is available. Because it's not only clinicians that can offer support, but there are other things that the person who is having this experience can do to kind of improve and decrease the impact of this illness on their life and day-to-day functioning. So we will talk about evaluations when we come back, and we'll look at what we do with the result of the evaluation and what are the other support system that we have in place that people can tap into, either as families, as individuals, as community, or even as a church. Because we know that there are other things that we can do apart from the things that are clinical that can support people who might be going through difficult issues like depression. Spiritual counseling is extremely important. I can't fault that to any extent. But the person who is doing the counseling needs to be aware of the features of depression and their role in trying to help that person manage the depression. So it's not only the spiritual guidance, but they can do more than spiritual guidance. So, but everything still boils down on education. So we need to find a way in which we need to get the church as a whole to begin to talk about things like this. Mental illness or psychological and emotional difficulties should not be alien to the church. It should actually be something that we talk about on a regular basis so that we all know and we can identify people who might be suffering from any form of low mood, depression, or issues like we're talking about tonight. Because I know that people do have confidence in church that they speak to. And for example, if somebody's talking to you about not sleeping well, struggling to sleep, struggling to eat, not motivated, losing weight, and things like that, then you as a person, if you know what this might actually be leading to or what it can entail, the complication or cluster of symptoms or the difficulties that this person is expressing to you, then you can signpost them to the right place. And I think one of the things that I mentioned earlier that is very, very important for us to know is that I said that people with depression might suffer with low self-esteem, lack of confidence, so they might find it difficult to actually ask for help. And this might be where we also come in as church to support people like that to go to their GP, or as family, husband supporting wife, wife supporting husband, parents supporting child to go and seek help. Because if you leave it to them, they might find it very, very difficult to take that step or might lack motivation to actually seek the support for their depression. And without additional intervention, like I said, moderate to severe depression will just not pass. And people cannot just snap out of it. Like some people will say, snap out of it and get your acts together. No, it doesn't work like that. It's beyond that. Mild depression over time might pass, but it might still reoccur. So that is different from somebody having moderate to severe depression that is severely impacting on their life or moderately impacting on their life and on their functioning. If that is the case, then there is need for proper evaluation. And not only proper evaluation, but proper intervention. Self-help helps, but this should be in addition, complementary to what the clinicians or the GPs will do. Because there is a limit to which the GPs can manage depression before they refer the person to a specialist unit. Because when you begin to have people with moderate depression that is not responding to initial treatment, and there begins to be threats to life, then they might need to refer to a specialist team like the community mental health team for a proper, more thorough specialist evaluation and intervention. Because there are things that people can do within the community mental health team, for instance, in which the GP cannot do, inpatient admission for a period of stability or review of medication or other things like that is possible within the community mental health team. And so when depression begins to go beyond mild and it's becoming moderate, that is not responding to the initial intervention that the GP has offered, or it's not improving, or it's getting worse, or it's having more impacts on the life, the family, the friends, and significant others, then there might be needs to refer to a specialist unit like the mental health team, or actually refer to more structured talking therapy than the low level counseling that can be offered through primary health care. And I'm going to tell us about some of these talking therapy that is available. The commonest that we have, the low intervention one, is what we call cognitive behavioral therapy. If you look at the spiritual aspect of our lives, I always like to look at it this way. We have a stable base, which is our identity in Christ. if you know who you are in Christ, your mindset, the way you think, the way you view things, the way you manage things will be based on your identity. And then your mindset will determine your habits, which will be in line with what you believe. The same thing when you look at depression, we'll talk about cognitive behavioral therapy, the way you think, the way you behave, and the way you look at things. When we come back from this short break, I will break down what I mean by cognitive behavioral therapy and the other levels of evaluations and interventions that we have with depression. Thank you.
Gospel music videos, gospel movies, inspiring teachings, educational programs, and lots of other exciting programs on LiveCom TV. LiveCom TV, just in time. My heart sings to you, Jesus. Oh, what can I give? What can I give to you? To thank you for all you've done for me. My heart sings. My heart sings. My heart sings. Oh,
Welcome back, and thank you for staying with us. We've been looking at depression and trying to answer some frequently asked questions about depression that people wanted answers to. And so we talked about depression, what it entails, the types of depression, and now we're getting to how do doctors make a diagnosis of depression? Why would they say I'm depressed? We know the symptoms. We know how long it goes on for. But that is a period of evaluation. So, for example, if somebody feels they are suffering with low mood that has been there for over 2 weeks with some of those symptoms, at least 5 of them, and it's not shifting, and they go to their GP, the GP will do an assessment of the symptoms, look at the period for which the symptoms has been going on, and also try and then support the person with a few low-level kind of intervention. And this could be information on how to deal with the symptoms, monitoring of the symptoms, and follow-up, and then possibly referral for further assessment and treatment if needed. But usually what you find is that when you come in there, low-level counseling with a GP or the primary health, mental health team might support you through there. But medication is not something that we want to jump at when we're talking about mild to moderate depression. So we look at things like low intensity intervention, such as self-help guided by doctors, or now with the advent of technology, we have computerized cognitive behavioral therapy. Like I was saying before the break, CBT is extremely useful because one of the things that we find in depression are these persistent negative thoughts, negative feeling of failure, of guilt, and things like that. So what we think determines how we behave. As I was talking about the spiritual level, our mindsets, our identity, our mindset, and our habits also way we think normally about ourselves will determine how we behave and how we see things around us. So those are the kind of things that we as clinicians might suggest as a way of dealing with mild to moderate depression. And physical activity programs. We know that we now have health trainers across the primary health care system. They support people with lifestyles. Habits like exercising releases natural endorphins, which we call the feel good chemicals in the body that helps you feel good about yourself. So naturally getting those things out without having to induce them by chemicals or arrange all those other things in the brain by chemicals is a useful way of managing mild to moderate depression. So we also have group cognitive therapy, which is available for mild to moderate, but we will now be looking at medication if all these things has failed and we're not having moderate or severe levels of depression, in which despite all that we've talked about, the mood is not getting better and the impact on life is not improving and there's no shift to the way the person is feeling about themselves, because the dangers of this is the person can or be there might be a threat to life, attempts at taking life and things like that, which is something that we want to avoid. And that's why it's very, very difficult not to want to intervene more aggressively when you're having moderate to severe depression. And part of this will be that the GP might either suggest medication or high intensive therapy such as individual CBT or behavioral activation combined with medication. So you can have a combination of interventions to bring the best result out of the whole system treatment. And you can also have support from other teams. Like I said, the structured talking therapy. So you can have the psychological services also coming into play. You can have the health and lifestyle advisors also helping out. And sometimes you can have the substance misuse service also coming in if the person is using alcohol, which you to self-medicate, or using any form of drugs to self-medicate that can complicate the treatment. Because when you have substance misuse in the light of depression, it makes managing and treating the depression a little bit more difficult unless you can get that substance out of the way and concentrate on actually interventions that work and not self-medication with illicit substances. So we assess and evaluate the severity and intensity of the low mood, and then we put interventions in place to mitigate against any possible risk. When we get to severe and complex depression, medication is always almost likely to be part of the process. And then you can talk about high intensity talking therapy and eventually things like electroconvulsive therapy that I alluded to earlier on our discussion. And then we can have other services that can help support the person out of hours, like the crisis team. And it might also be that we need to involve all these different treatments to get the best outcome for the patient. And hospital treatment can be indicated in emergencies when somebody presents with severe depression with suicidal tendencies or severe depression with psychosis. That might indicate a short period of stay in hospital or possibly even longer period of stay to either review medication, to start medication, or to stabilize medication. So that is always a possibility. What other type of talking therapies do we have to manage depression? We've talked about cognitive behavioral therapy. Also, there is psychodynamic therapy. I'm not going to go into the details of this individual therapy, but just to kind of tell us that one art doesn't fit all. So there are other forms of talking therapy that might be useful for different people because of different reasons. So we've talked about problem solving therapy, for example, interpersonal therapy, made mention of behavioral activations, group therapy. Sometimes it might entail relationship counseling, or in people who have had a major event that's led to the depression, such as bereavement. We might be suggesting things like bereavement counseling or mindfulness based therapy and counseling. So, when we talk about the type of therapy we offer to people, it is based on the type of symptoms and the severity of their depression. So, when everything is more settled and the acute phase or the crisis phase is over, medication is stable, and all other things are put in place, we might suggest to some people that mindfulness based CBT can be helpful if the depression comes back, so that we can have a sustained period of normality and avoid things that will lead to inpatient admission. For example, when you have an acute presentation of depression that is severe. And here they can also learn things like mindfulness, breathing exercises, and meditations with CBT. For those who struggle with their depression coming back, when I mentioned recurrent depression, or they tend to relapse more often, things like mindfulness based CBT has been found to be extremely useful. Computerized based CBT also is one way of treating mild to moderate depression, in which we kind of allow the person to kind of lead the process and learn CBT techniques using the computer. This is quite good because it's convenient, it's at their own time, and they can manage things through at their own pace. It will be exactly the same as if they were going through face-to-face CBT, for example. We always advocate that this can be a way of preventing the symptoms from coming back. As part of interesting, I was talking about the blues after somebody has had a. One of the things that we talk about in computer CBT is also beating the blues. That cloud where you can't see any out. There's this darkness looming. There's this of doom. There's this pitch where you can't see the end of it. That is what we're talking about. Try to manage that and manage it effectively. Antidepressants, we have types of antidepressants, and so the GP can talk about this. So we're going to be ending here today. We'll probably from where we've ended here next week, but we've probably covered all. These are self-help techniques, which I'll mention briefly next before we go to our next topic. Thank you.
Gospel music videos, gospel movies, inspiring teachings, educational programs, and lots of other exciting programs on LiveCom TV. LiveCom TV, just in time. My heart sings to you, Jesus. Oh, what can I give? What can I give to you? So thank you for all you've done for me. My heart My heart sings. Oh, what can I bring to you, God? What can I bring to you? But my sacrifice. My heart sings. Hear my heart. Oh, sing it again. What can I give to you, God? Yeah. Give to you. Thank you for all. You've done for me. My heart sings. My heart sings. Oh, Baba. What can I bring to you, God? Yeah, yeah. Bring to you for my sacrifice. My heart sings. Hear my heart. Oh, Lord, you have done. Nobody else could do. I owe you worship.
Gospel music videos, gospel movies, inspiring teachings, educational programs, and lots of other exciting programs on LiveCom TV. LiveCom TV, just in time.